Oh, yeah, can we go back again? I'm sorry. I think it stopped. I didn't do it.
Okay. Let me go back.
Okay, here we go.
Okay, hi. My name is Karen Rose. I'm a professor in the College of Nursing, where I direct the Center for Healthy Aging, Self-Management, and Complex Care. It's a pleasure to be with you today to talk about hidden populations in research and how best to access them. My program of research focuses on dementia family caregivers and how to best support them. And so I'm going to give you a little bit of context of who dementia family caregivers are and really try to relate this patient population to other patient populations that can be hidden, and again, really focus on best ways to recruit these patient populations and to engage them in clinical research. So dementia family caregivers, even though there are more than 5 million people in the adults in the United States who have Alzheimer's disease or related dementia, they still are a hidden patient population. Because our population is aging, certainly here in the US and worldwide as well, there will be an estimated almost 14 million people in the United States will have Alzheimer's disease or related disorder by the year 2050. So in 30 years, really the population in this disease entity will have exploded, if you will. Additionally, it's estimated that approximately 4 family members provide care for each person with Alzheimer's disease. So there are over 16 million family members in the United States currently providing care, and estimated cost amount of care is 18.6 billion hours of care at an estimated cost of over $241 billion. So I give you these big numbers and you must think to yourself, why are these hidden? Why, there's so many people with Alzheimer's disease or a related disorder and so many family members. So why are they difficult to access? So let me tell you a little bit more about the story. So why are they hard to recruit? I'll tell you that they're often hidden in the healthcare system, that many people with memory changes still consider that to be a normal part of aging and don't access care for that. Many others fear the diagnosis, and there's a lot of confusion around the diagnostic terms. So people may get a diagnosis of Alzheimer's disease. They may get a diagnosis of dementia, and that's confusing. They may get a diagnosis of memory loss, and that's confusing as well. So there's a lot of confusion around the diagnostic terms. And I will then tell you that as a result of this, many people don't access formal services. So there are many, many community-based services for persons with Alzheimer's disease and related disorders. And yet, by and large, we still are challenged with getting people to access these. Second reason is that many caregivers, family members, really don't consider themselves to be caregivers or carers, as they're more often referred to in the UK. They just consider themselves to be family and friends who are helping out. And so when we try to reach them by recruitment materials that say we're looking for caregivers, people think, well, that's not me. I'm a spouse, I'm a daughter-in-law. That they must be talking about someone else because I'm just doing my role. I'm being a good spouse, daughter, whatever that is. So many ways, some of the words that we use, people don't relate to. And then lastly, I want to spend a little bit of time on the stigma of this diagnosis. It's a highly stigmatized diagnosis. And what we've learned about this diagnosis, similarly to what we've learned about in the past, the diagnosis of HIV or severe psychiatric diagnoses, people feel very stigmatized by that and want to conceal the diagnosis. That in turn then leads them, all of these collectively, lead to them to be a hard to reach patient population. So I want to spend a bit of time on stigma, and I think other speakers are talking about this too, but in terms of stigma related to dementia, The stigma, we know, prevents early, accurate diagnosis. People don't want to be labeled with a diagnosis of Alzheimer's disease or with the diagnosis of dementia. I will tell you that I think this is changing, but by and large, this is still a highly stigmatized diagnosis. Again, because people aren't getting accurate diagnosis, it prevents treatment options that are available to them or that they are able to, or even know about. And additionally, it prevents access to support services. We know too from studies that stigma, dementia-associated stigma is associated with anxiety, behavioral symptoms of dementia, depression, self-esteem, health and activity, lack of health and activity participation, and lack of participation in clinical trials. And this holds true both for people with the disease and for their family caregivers as well. Worldwide, there was an Alzheimer's Disease International World Report specifically on stigma that came out in 2012. And when they talked to the general population, about 2,500 people were interviewed for this. 60% of the respondents said that they believed that the stigma of dementia was due to a lack of public awareness. So people just weren't aware of what dementia is, what are the signs and symptoms of it, and so people fear it. That there was a 75% negative association with people who had dementia. People wanted not to be associated with them, really wanted to limit their interactions with them. And there was a belief that up to 25% of people hide their diagnosis. I'd suggest that that number is higher based on my own clinical background. And that up to 40% of people withdraw from everyday activities. So again, if they're not interacting and not being a part of society, if they were withdrawing from their usual activities, from being involved with meeting groups, with groups that that were associated with leisure activities, many even withdraw from church or from their synagogues or from places of worship. So they're difficult to find because as a result of the stigma of this diagnosis, people turn inward. So what we know too about the stigma of the diagnosis, that it seems to be worse among people with limited disease knowledge, no surprise there, limited contact with people who've had the diagnosis in the past. Men, it's interesting that men carry a higher stigma toward people with dementia. Younger individuals carry a higher stigma toward the dementia diagnosis. And that stigma really is contextualized based on people's ethnicity and culture. I will tell you too that I think that since these are very recent data, 2018, but it's interesting because what we're finding out more and more about caregivers is that up to 25% of family members who are caring for persons with an Alzheimer's disease or a dementia diagnosis are millennials. So that's a large number, and not when we typically think of family caregivers, we think of the typical 57, 58-year-old woman who's a daughter or daughter-in-law, or we think of older adults who are spousal caregivers. But what we're learning is that really targeting younger individuals is necessary too in our recruitment. In some of my own work around stigma, what we found interviewing family members was that the overall theme was really shame. People still feel very shameful about receiving this diagnosis. And you'll see this is data, we published this in 2019 based on interviews that we conducted in 2017 with family members who just received the diagnosis within a year of their loved one having a dementia diagnosis. So we saw the overarching theme was shame, and that people felt shunned by others once they revealed that they had a diagnosis. People worked very hard to conceal the diagnosis, didn't want anyone to know it, and oftentimes that meant even disclosing it to other family members, and they felt silenced. They really tried to silence themselves so that they wouldn't stand out in a crowd, wouldn't stand out with family members or other friends. So again, all of this relates back to why they're so difficult to recruit and why they're a hidden population. They tend to go underground. So the implications of this for study recruitment, incredibly important that you host focus groups to identify key wording and recruitment sites to use. Again, I've identified that some of the words that we typically use clinically, Alzheimer's disease, related dementia, mild cognitive impairment, caregiver, are not words that people with this disease or their family members or neighbors or loved ones identify with. So understanding what words they identify with is really very important. And I would tell you that if you know one family caregiver, you know one family caregiver, that it's incredibly important to identify potential recruitment sites in the area and to get to know those recruitment sites, because the demographics do matter with how they relate. You may need more than one study recruitment brochure or approach to customize the language. That you may need different pictures to discrete patient populations, because what we know in this population as well as in others is that people want to see themselves. And if they don't see themselves in a picture, they think, well, then this isn't for me. I don't see people who look like me, who dress like me, who have similar family members to me. So really pictures can be very powerful, both positively and negatively. Querying those, following up with those who you've successfully recruited. What worked, what didn't work, what could have been better, what made them stick with the clinical trial, what were reasons that were maybe barriers or hardships for them. And then having champions at your sites for recruiters and educating. There is literature to suggest that healthcare providers themselves are stigmatizing of persons with this disease and their family members. So it would be a mistake to make an assumption that everyone at a particular site has a particular sensitivity to this disease. They don't, or to any disease. What you'll see is that nationally, through the National Institute of Aging at NIH, there was a whole strategy for recruitment and participation in Alzheimer's disease and related dementia clinical research, specifically the considerations around the stigma of it. So it's a huge problem, it's a national problem, and you just know that with this hidden population that you're going to have to spend time and energy addressing that up front. So knowing your audience for this hidden population, from the recruitment perspective, I said, again, what words do people use to describe their health status? Is it dementia? Is it Alzheimer's? Is it memory problem? Whatever it may be. I know from my own family background in this area, it used to be called hardening of the arteries. And so some older adults still think of it in that context as well. So really understanding what patients you're trying to recruit and what words resonate with them is very important. Understanding how people access resources. The healthcare system is certainly one resource that people use, but you can't always count on that being your only site of recruitment. People use barbershops to recruit very successfully for different patient populations. I'm in the midst of work right now where we're using online platforms, and we've been incredibly successful, but this is because we're targeting a specific group of patient of LGBTQ family caregivers, and we know that they're online. So that was a successful recruitment strategy for us. The partnerships are critical with your clinics, with advocacy groups. So the Alzheimer's Association, for example, for the work that I do, employee assistance programs, any other critical partnership that you might think. And what I mean by that is that they're critical. You need to build trust there. You need to show up, and it needs to be mutually agreed upon that this is an area that they're interested in, that this is an area that they will advocate for you, that this is an area of science that they really see as important, and that you're doing meaningful work and that you can be trusted. Again, champions at recruitment sites are critical, and best strategies for how to build trust and retain these champions, I think I've just outlined. Again, showing up, being transparent, being genuinely concerned, listening, being active a listener to, because every recruitment site has their own environment and culture, if you will. So understanding that, recognizing that, and flexing your recruitment strategies to meet the needs of that recruitment site are critical. So in terms of retention of challenging patient populations, understanding what incentives might be important to these participants. Is it access to education? Is it social support, or do they want group interactions? Are there monetary incentives that are important? Or is it truly based on altruism and speaking more to that and identifying that and encouraging them in that way? I've used all of these in terms of incentives to different patients, that recruitment sites that I've used, and they're all equally important. It's just understanding and acknowledging and really aligning the incentives with what participants at the different recruitment sites see as important to them and meaningful to them. The other thing I say is that in the context of retention, understanding that life happens. And right now in the midst of our pandemic, we certainly understand that life changes. So certainly for this patient population, life does change. Typically older adults, there can be things that happen. They get hospitalized, they fall. There are other life events maybe that are occurring within the lives of caregivers. So really thinking hard about how your study protocol can flex for these life events. Some anticipated, certainly some unanticipated. So key points about recruitment and retaining and accessing this patient population, this challenging or hidden population, would be know as much as you can about your potential participants. Spend that uptime homework time to really get to know who you're trying to recruit and what the norms are for these people. That words matter. Words can be very powerful in a positive and negative light. They can be stigmatizing, and we certainly don't want to do anything ever to further stigmatize the patients that we're trying to recruit and ultimately trying to help through our work. And that building trust is essential. Certainly with the people that you're trying to recruit, with your retention efforts, with your clinical sites, your clinical liaisons. So I think these three key points will get you where you want to go. So in conclusion, I just say that there's still an awful lot of work to be done in this area, that we are constantly being updated in terms of best practices for recruitment. And certainly I'd say to you that there's incredible work being done on this nationally and internationally. And I'm sure too in your patient populations, but it's hard work, it's time intensive, and it's incredibly worthwhile. Good, and I'm glad to entertain questions. You can certainly email me. I'm available at rose.1482@osu.edu. And thank you so much for your time and attention today.